Thank you for letting me speak and present these results to you. My name is Tim Spalding. I've been involved with Episurf really since early on and undertaking this surgery. This is partly in Coventry and then also down at the Cleveland Clinic London, where I'm now based as well. So the focus here is really on the clinical outcomes, and that's what I've been invited to present to you. You've heard that there is this treatment gap between the biological solutions at one end of the spectrum and then the knee replacement at the other end of the spectrum. And that leaves a large number of people who are in trouble with the knee, and we need this treatment option for those patients. We know the Episealer then has these various options to treat from different sizes and different locations to cover specific lesions on the joint surface. So I want to focus on the results that we've undertaken, and this is essentially a study cohort that we've had 2-year results published, and then now we have updated 5-year results, and then we have some larger cohort of patients from those surgeons who have been treating patients over the last 5 years or so, giving more data on the specific outcomes that we can expect. And then we'll just discuss at the end the reasons for success and maybe the indications where it's gone to now. So there have been several publications over the years, the initial preclinical work and then the clinical results that have come out. And the focus here I want to talk about is this specific multi-center study. So that's 80 patients in a consecutive series from the surgeons that you can see on the right-hand side of the slide there. And those surgeons have put their patients into this study where we keep the comprehensive data and then can analyze that and look at the results. So this paper took the 80 patients, and it's a prospective 24-month outcome study you can see here on the left. So it takes the right size defects where biological repair is no longer indicated, but it's a single lesion. So patients that may have had 2 lesions treated are not included in this. And the tibia has got to be good and the alignment has to be good as well. So then we kept the focus data on them pre-op, 3, 6, 12, 24 months post-op, and the KOOS score, which is a specific score that collects questions about your patient outcome, and then the visual analog score. These are the 2 main scores that we're using. So that cohort then from 80 gets to 75. 2 had revisions, so we don't have the outcome scores because this is mainly looking at the patient reported outcome scores. 1 declined to stay in the study and 2 had incomplete data, so we couldn't include those. But this wants to be the comprehensive data on the study cohort. Now, you can see then 59% female, mean age 48, young 27 to 69, BMI, body mass index at 28. We need to be careful about that in considering the indications. But 65% have had previous treatment, and I think this is important because it reflects on the outcomes, who gets good results. So previous microfracture, failed cartilage repair treatments. So 10 on the trochlea, the front part of the knee, and then the rest on the main weight-bearing part. 25 with twin implants and 40 with the solo single implants. So that's 65 on the condyles. The key results then, this is the different KOOS domains. Now the knee outcome orthopedic arthritis score is then breaks it down into different domains by pain, symptoms, activities of daily living, then sport score and quality of life. And over time, then there's different bars here from pre-op, 3 months, 12 months, and 24 months. We see the improvement in those scores, the different domains of the overall functional score improving over time. So this gives us that improvement and gives us a good overview of that recovery, matched by the visual analog score, which we want to decrease. We want the KOOS to increase, but the visual analog score for pain, in other words, what pain have you got, to decrease pre-op, 3 months, 6 months, 12 months. So that's maintained, showing a slight drop at the 24 months in that group. So we've further taken that data and then tried to break it down by the implant type on the side and the visual analog score by implant type on this right-hand side. This is trying to look at what the difference is, but we've only got a small number of patients here, and at this stage they don't look to be different. They may appear the green is a bit higher, which is the trochlea, but it's not a statistical significant difference. But it's important if we can try and understand which patients are doing well and which ones are not doing so well. This was analysis by whether they've had previous cartilage treatment, because that's very important to know if we can help those that have had previous surgery where it has failed. Now, it may appear at the moment that primary cases and prior cartilage surgery, but the range is so big this does not reach any statistical significance, but it still seems good in those patients that have had previous cartilage repair. And this is something, as the results go on, we need to be looking for. Additionally, in this group, we've had one that got an infection, had to be revised. The implant was removed outside of that 24 months window, and two had arthroscopy for treating ongoing pain to help them, and one deep vein thrombosis. So that is the 2-year results, consecutive series of where we have the 2-year results. And now we've extended out to 5 years in that same group. And we have the first 50 patients who are reaching this 5-year point. At the moment, we have the patient-reported data in 37. 7 we're still trying to collect and chase. 1, the same one, withdrew consent, didn't want to stay in the study. And then we've now got 4 revisions, and 1 had infection, as you heard in the last bit, has been removed. So that's 4 revisions out of this group. Now extending that COOS score, again, slightly different way of expressing it. We've got the same domains at the bottom: pain, symptoms, activity of living, and then the blue line pre-op, and going up afterwards to the 24 months and the 60 months 5-year point. So the scores, that functional scores reported by the patient, seem to be maintained out to this time. 3 months getting there, and then the rest, it seems to stay the same. So this is very reassuring to see those results at that point. And this is a similar way of reflecting it. The pain scores going up and staying constant, activity of daily living. So we want a high score on the COOS. And then the other way of looking at COOS is to put the scores together as a total score. And the way that's done is you take 4 of the domains. We actually take out the activity of daily living because that's got such a large number of questions. It rather drowns out the other changes. So we have the mean of 4 of the domains. And then we can see the scores going up from pre-op and staying good out to 60 months. So that's a good reflection of the outcomes and maintained over this time. That's also then reflective of the visual analog score for pain. When they get pain, that has come down and stayed down. Now, the subgroup analysis, again, we're trying to look at whether something makes a difference. And interestingly, the points from this is the twin implant, which is the larger one in orange, seems to show slightly better scores over the time for that COOS 4, the aggregate score, compared to the solo. The worry is that if a lesion is too big, then it may not do so well with the implant. And then the second part on the right here is whether the trochlear or the end of the bone, the trochlear being the front of the bone, where the kneecap articulates, whether that is worse or better. And it seems on this early data that the trochlear is doing very well compared to the condyle. So it's actually not putting us off by doing the trochlear. So that's the message from this. Next analysis was by defect size, with the dotted blue line being the small lesions, and then orange moderate and the purple bigger lesions. And again, the message from this is that the larger lesions are doing as well, if not better almost, than the smaller lesions, which is very reassuring, because the worry is that too big an implant will do badly. And that's going to be reflected on this graph. Just visually looking at it, the small lesions seem to improve from bottom to top here. Then the medium size lesions improve, and the larger lesions maybe improve as well, if not more. But there's 9 patients in this larger area group. So it's the message is that large lesions seem to do well as small lesions. So now, if we then, the third bit of this results bit is looking at the overall results from this group. So we've taken our surgeons and focused on the first lot of patients that were done. Meanwhile, we've continued doing operations. So now we've got, from those 6 surgeon centers, we've got 186 who have got a minimum 12 months follow-up. So this is rolled on, keeping data on other patients. So you can see female and male numbers, mean age 48, Location mostly on the medial femoral condyle, the main weight-bearing part. The lateral femoral condyle, the main, again, the weight-bearing part on the outer side of the knee, 17. Trochlear and multiple lesions. So this is creeping in, whereas before we'd taken out where 2 lesions had been treated. We've now got 10 patients who had multiple lesions. And the implants of range again here. Solo, in fact, now more twins. That's the larger implant. And then on the trochlear, they're all solo implants. And then multiple is in the 10 patients. So it seemed to be more twins. And the results on the right-hand side, the aggregated, that COOS4 again for 186, recognizing that only 45 are out to this 60 months time. We see the improvement in that COOS score is maintained. So this is very similar to the focused cohort that we had, where we've got the 37 out to the time point. Putting it in a similar way, going out to 12 months and then beyond, we're seeing the scores improved and maintained over time for the different domains: pain, symptoms, ADL, sport, and quality of life again. So similar to the focused group, so in the general mix, in other words, and the visual analog score of pain coming down as well, maintained over time. So this is nice to see that reflected in other patients. So this analysis again by lesion, and if I just put the other graph up that we had before, slightly confusing because on the left-hand side we're looking condyles versus trochlear in the overall group of these 186 compared to then the bottom right here, condyles, trochlear in our focus group. Look like the trochlear is doing better in this wider group. Maybe not so clear as doing better, but it's certainly not worse. And generally the trochlear, the patellofemoral joint, the front of the knee, has a reputation of doing worse for some cartilage repair lesions. And then on the right-hand side, the condyle, the solo against the twin, then they seem equal on the bigger group, but might have appeared better on the twin when we had the focus group. So it's reflecting similar things, just diluted down a bit. The COOS4 by the size of that treated area, again, reflected they're all improving. Now, there's very few patients we've set out to the 60 months, so this drop down here from the smaller lesions is probably not reflecting true difference because there's only small numbers at this point. We mentioned that 10 patients had multiple implants, and the results from those that had 2 implants, therefore you're covering 2 areas in the knee and not just the one area, seem as good as those patients that just had the single implants. It's only 10, but it's not a flat line where those have not improved at all. So that's another message from this. So multiple implants, when you see 2 areas, 3 areas, then they can be treated. So let's put all these results together then and try and work out what we've said. And we've taken that select cohort, 75 implants at 2 years, and shown this low failure rate, 2 at that point. They've had good clinical improvement. We're measuring that on the patient-reported outcomes. As a surgeon, we're happy that this design is accurate and the depth is easy to achieve. You can put it exactly where it wants to be, and that damage reporting and the instrumentation allows us to do that. Taking the first 50 out at 5 years, the failure rate is still low, and that is low, 8%. 4 out of the 50 failed at that point. That is good. And there's a variety of the implants and includes the early cases in that series. So in the wider group of all those surgeons, again, that improvement seems consistent and maintained over time, and there doesn't seem to be a clear difference between one lesion being better than another, or the trochlear, or the twin, or the solo. So all the implants, provided we do it accurately, seem to be consistent in the results. So some of the failures, yeah, we analyze that in our knee discussion and work out, well, is there some factor that will more often lead to failure or something, and that of course is the ongoing work. We think some of the early cases, there was some poor matching for the implant and so less accurate, and that might be an excuse for the failure. And then in other cases, we've extended the indication and really stretched doing it for a larger lesion. And that's what we want to know. If you do it for a bigger lesion, is it still good? So essentially, we know this works when the indications are good, but what we've then got to work on is, can we push the limit And can this work on the borderline cases and still get the good results that last, buying time for the patient? Let me finish with some little examples, right? Here's a guy, so he's got this is the damage marking we send the MRI scan off, we see that damage marking. It can be covered by this twin implant. Great, it covers all of that area, leaving that bit not quite so covered, but happy at 2 years, delighted with the result, responded well. You can do bowls, 18 holes of golf. So that's bowls kneeling down, 18 holes of golf, getting in and out of the bunkers, of course. So he's back to work, outdoor work, and he feels like he can run, so he's loving it. And these are the happy situations that we get. This patient, this is a way of presenting the results. You can see the implant has covered the defect, and the individual scores for pain on that one, symptoms, activities of daily living. This is the improvement for that individual patient on the results. So he's a happy patient as well. And what he is, he's 43, he's an outdoor active farmer, 3 or 4 years history of pain and big problems with his collapsed area on his joint, with pain on walking, and has to flick his leg out straight so he doesn't take weight on the bent knee. So it avoids taking that load on the painful area. Getting some some imagery here that we've got the MRI scans, you can see this damaged area. So we can then fill that and cover that with the mini metal implant to then take away that pain on walking from this damaged bone marrow area. Operation pictures warning. So there is the damaged area, knee open on the medial inner side. Right, and then using the 3D printed guide, accurately placing and exactly covers the position. It's amazingly stable when that's in place. And then ream it, do the dummy in there to check that the height is right and exactly seat it, or go in a bit further. And then taking the guide off, and then finally putting on the implant to cover that damaged area. So on the surgeon side, it really is very accurate to do that. So now this is the latest thing. We contacted him recently. He says, I'm feeling 100% better than before surgery, occasional ache from time to time, but no obvious things that make it sore. And he's moved to France for some reason. So he's happy. All right, so why do we get these good results? I think that the indication is important, and we focus on that. And the size of the defect doesn't seem to matter. We've got to cover it properly, and the implant's got to be good, and it's got to be even. And then we'll get the good results. If we leave it a bit uncovered, that's the worry area for extending the indications. But getting the indication right is important. It is for these patients with specific lesions. The surrounding cartilage is good, and they've got pain localized to those damaged areas that gives us the results. They need to have tried conservative treatment, non-operative treatment before. And that they're happy to accept the surgical route, having tried other things before. I think the ability to accurately map out the area and have an implant that exactly covers that point is ideal. Be able to play with it on the screen, on the damage marking, and to plan and know, and then even go back to the company and say, actually, can I have one a bit smaller? I don't think you need a twin here. Then that's the advantage of it, and we can play with that damage marking to be happy that it's covering the defect. So that's a key factor to this. And then getting that final design and the actual positioning of the guide it's going to sit. We have that printed out. It's on the wall in the operating room, so we can exactly see where it's got to go, and it fits so well. Then you ream in the right place to put that implant exactly covering the damaged area, taking away that pressure on the bone. We focus on the indications, and recently I put these together as this sort of 10 key points to exactly make the indications right. So this is our in zone. This is the right times to be doing this. The focal lesion, the correct area of damage on the other part of the joint to make sure there's not damage on the corresponding surface, and that the alignment is good. We don't like smoking because that slows down healing, and the ideal weight. And essentially, these are the sort of defined indications that we want to get the best results for this. So I appreciate this is a rush through of different stages of the results, but we've really focused on understanding those results, and then that leads to the correct indications and allowing to continue doing it. So I hope that's given you the information. I'm very happy to take some questions on that.
Thank you, Mr. Spalding, for that presentation, and I welcome you to the Q&A session. I'm going to start off by asking you to elaborate on the patient-doctor dynamics and how patients react to the possibility of getting an Episealer implant versus the traditional treatment methods.
Yeah, that's good, because I think we have a pathway with patients to assess them, MRI scan, understanding exactly the nature of their symptoms, and then go down like a pathway of treatment, or it's almost like explaining an option, a ladder of treatment for things that can be done. If it's a meniscus tear, then that's arthroscopy. If it's damage on the joint surface, then we have traditionally less options to treat that. And from the MRI scan, initially diagnosing that area as a source of pain, and then trying the physiotherapy and maybe some injections in the knee first, before then broaching the subject of the partial resurfacing. That's how it works.
And the patient is, as we know, in the so-called treatment gap. But could you elaborate on what the perfect candidate looks like for Episealer, and what criteria must be met for the best clinical outcome?
Ideally, then, so it's the 40, 45-year-old up to 65 who's got pain on activity in the specific compartments. It could be the front of the knee, could be the inner medial side on walking, who wants to be active still, getting some limitation. The sport-wise afterwards, running, we can allow running. It's not the main intention. Whether they should run or not is different, but we can allow that. They want to be keen. Alignment should be good, so not particularly too bow-legged, because that means they're taking more weight on it. And their weight reasonably under control, not high BMI. That's your ideal patient who's tried other things and then motivated for the recovery.
And you have used Episealer many times, but generally speaking, what does the interest and curiosity look like among knee surgeons when it comes to new products? What are the key obstacles to getting a new product like Episealer to become a more standardized treatment method?
The surgeon wants to know results and wants to know the case profile of someone who needs it, who is at ideal indication, as you just asked. And once that then fits, so much of the time previously we've just said, well, look, you've had this, there's nothing much more we can do, you just need to look after your knee until it's time for knee replacement. So once we know there is this option and that it's available, and then you've got the published series, and we're going to finish publishing the 5-year results, then a surgeon has something to look at. You see a case profile and you see the published results. Then it becomes an option and available, and it fills another little gap of patients. It's got this excellent narrow indication, which is so good for when we see the patients who then need it. That's the main obstacles, is that data and then getting it out there.
And there is long-term data now on 5 years, but how do you expect the even longer-term data to look like, let's say 9 to 10 years?
Then what we've seen from results of another type of mini metal implant, the hemicap unicap, is that those that survived, there were failures early on, but those that survived, that have the good results, then it tends to last once it's there. And in that sense, at the 10-year point, we would anticipate the results should still be good. What we're not seeing is big erosion on the other side of the joint from the metal sort of nail in your shoe, as it were. It doesn't seem to be appearing. So once you've sealed that area and covered the damaged area, we're not seeing this progression of the damage. So I would foresee that the results stay good. There's going to be a few failures, but you marry that against the idea we've bought time for people that's got them from their 45 to 60. 65, and then maybe the rest of the knee is beginning to wear a bit more, then you can convert to a knee replacement very easily. So you've bought quality of life, which is a very valid outcome measure.
And in your career, you have clearly seen many different orthopedic products coming and going. And Episurf seems to be very diligent in collecting clinical data. In your experience with the data available, is the product being positioned for a wider commercialization?
Yes, that knowledge of the outcome, this focused group, is very influential in being able to position that. It's in everyone's practice, you've got a number of patients where this is suitable for. So many surgeons don't really know about this, or they just dismiss it because they don't know the detail. So in that sense, we are very much meeting other surgeons. We run the meetings, and that's great. So the education part matches the data collection, because then you've got something to say. We've got the technique, we've got the focused results, and then that leads to the indication, and then you've got experience of people slightly pushing the limit and expanding that. So yes, that's how it expands out there to fill, and for the many surgeons that don't yet know about this.
And you're also on Episurf's advisory board. I'm wondering if you can tell us what attracted you to this role, and in your opinion, what key steps the company needs to take in order to establish itself as a challenging player in this field.
Yeah, so I've been interested in cartilage repair a long time. I used to be Navy initially, and we had access to growing cartilage in the lab to be able to treat this as the Genzyme technique, and then different other cartilage repair. So that's been a drive all along, and then this new technology sprung up and it became very appealing. So the role on the medical advisory board is literally to advise, and they sometimes don't listen to us on the board, and that's fine. We give that information, get the data, answering almost the questions you're answering now, giving that advice to do that. So they've been, to me, nicely responsive. I'm not just saying that, it is actually because we can give advice with the key surgeons that are involved to direct and to how to get this product out there, plus keeping the results, because if it's not good, then we would say it's not good and wouldn't be involved. That's how it works. So from my point of view, it's been a good journey.
And a final question. In your opinion, what are the key competitive threats that could hinder Episealer from becoming a more widely implemented implant?
The other products, right? The HemiCap, Unicap, which is a much more off-the-shelf item, not customized to the patient, has the early series showed some not so good results on it, and therefore we've been able to show in our results, hopefully, that this seems to be better. There's not a head-to-head trial, and the indications for getting this right is what we've then focused on. So in that sense, at the moment, this is a neater thing because you can exactly position it. I can't emphasize more the equipment, the guide to put it in. That 3D printed guide is a key part of the success here. That makes it doable for surgeons to do, and that's an important part. Then the BioPoly, which is a polyethylene implant, again, that's good, and I think that probably is a threat. The trouble is they've got no results on that yet. There's one paper. I know they're writing up some other results in a small series, and they've been pushing down to lower age groups. I think that's an interesting product, but very few results on it, and that's why it's not really taken off. The other forms of cartilage repair are all still for the biological group. New ways of trying to grow articular surface, they just don't do well when we're over this 40, 45. The biological solutions are not so good. So those are less competitive. Osteochondral allografts, the donor fresh viable cartilage, again, results over 40, over 45, less good. They still work, but less good. So those other competitors are not really there for this 45 to 60-year-old focal lesion.
Thank you very much, Mr. Spalding, for the presentation and the participation in this Q&A session.
Well, thank you very much for letting me do this.